A very good afternoon to all. I am Dr. Minal. I am from Jaipur and I am in charge and head of the Department of Endocrinology, Manipal Hospital, Jaipur. We will be talking today on pregnancy diabetes. When we talk of pregnancy and diabetes, they are broadly the three groups. One, a type 1 women getting pregnant, another type 2 getting pregnant, and third that the pregnancy is per se the cause of diabetes, and only during gestation, during pregnancy, the woman comes to know of her poor glycemic control or the hyperglycemia. Type 1 diabetic women getting pregnant. If it is a planned pregnancy, I would suggest keep all your patients at HbA1c less than 6.5. If the pregnancy is an unplanned one, then whatever the entry point of HbA1c may be, try to keep the targets within control and try to achieve the targets as early as possible. And the best regime to follow with type 1 women and pregnancy is the Basal Bolus regime. Your women should be, all pregnant women with type 1 diabetes should be on a basal insulin for the bedtime and the bolus insulin for the 3 meals, the 3 major meals, that is the breakfast, lunch and dinner. The pregnancy targets of blood glucose control are very tight. We try to keep all the fasting blood glucose below 90 mg per dl and all the post meal blood glucose below 120 mg per dl. HbA1c has no direct value during pregnancy once the pregnancy has already set in, but if you can keep HbA1c under control, it would be really good for the endpoint with the complications. We all know the complications of pregnancy diabetes. It affects women as well as the baby. So there are 2 generations are at risk, the mother herself and the baby. All the babies of the pregnant diabetic patients are at higher risk of hyperglycemia, and hyperglycemia leads to macrosomia, and this macrosomic babies when delivered are more vulnerable to hypoglycemia because suddenly the insulin support has been taken off, and hypoglycemia, other metabolic complications like hypocalcemia, hypomagnesemia, these babies may also lead to obese babies or obese young adults, and these children are more likely to develop type 2 diabetes in the later life. When we talk of type 2 diabetes women getting pregnant, again if it is a planned pregnancy, the targets are HbA1c 6.5. The only difference here comes that if a type 2 diabetic woman is getting pregnant and if she is on oral hypoglycemics, as per the latest recommendations, they can be continued with metformin and glyburide. But if the glycemic control is significantly poor and if the complications are there, especially if the pregnancy worsens the complications of diabetes, especially the diabetic retinopathy and the nephropathy, then we can, with the consensus of the patient, switch the patient to insulin. And the targets remain the same. The fasting blood glucose should be 90 and the post meal blood glucose should be 120. When a gestational diabetes mother or a gestational diabetes case comes to you, most of the gestational diabetes are diagnosed around 24 to 28 weeks, but that does not rule out the screening. The screening should become a habit at the very first entry point into your clinic. So whenever you are seeing the patient for the first time, maybe in the first trimester or second or third, whatever, do not worry about the fed state, do not worry about the glucose load, just do one blood glucose prick with a glucometer at your clinic. So that random check is very important, at least for the early screening. And if you diagnose a gestational diabetes, then again the most important part is your diet counseling, your lifestyle modification. You have to ask the patient to avoid all sweets, all fried items and all the refined food, avoiding all juices, extra calories, taking healthy nutrition and a regular walk, trying to keep all the targets within limit, and the patient should be on insulin ideally. If the woman is a elderly with a overweight profile, you can think of metformin if the blood glucose are just borderline, but if the blood glucose are very high, and the HbA1c normally in gestational diabetes should be normal if it is a gestational diabetes, but if the HbA1c is high and a pointer towards an early existing diabetes which was actually earlier missed, then you can start with insulin as well. So that all goes in consensus with, after the consensus with the patient and the planning with the patient.